Hi everybody, let's go ahead and take a quality improvement article and put it into this non-research evaluation or evidence table template. So remember we had the columns in the quantitative and the qualitative, and here we have columns as well, but the information it's just asking for is a bit different because we are talking about non-research versus research. Really quickly, I just want to remind you that QI improvement or quality improvement articles oftentimes look like research articles, but go to there's a couple links in your Canvas that can take you out there and tell you the specific difference between QI and research. I think students have asked me in the past, just because you use statistics to evaluate your results, that does not mean it's research. That's just using mathematics to show us what any changes were. Additionally, in healthcare systems, QI projects pretty much always go through ethical review or to the IRB, but most of the time they are considered exempt. But going through the IRB is essential because people want to keep track of things, and there are a few things they need to check because IRB oversight is needed if there is NIH funding, National Institute of Healthcare funding, or sometimes QI projects may randomize, and that's okay. That still doesn't mean it's research, but that is a research component. And sometimes QI projects may increase, depending on what they're doing, may have a little bit of increased risk for patients. So that's when IRB oversight is needed a little bit more as well. But still, they are very different. There is a specific research is to generalize the new knowledge that was created to the population as a whole. And I talk about population in the world, whereas QI is local knowledge. It is created, it is taking that evidence and applying it to a healthcare system or a site, something locally, and trying to make an immediate change in practice. So let's go back here. So it is different. All right, so let's look at this article. We're going to look at reducing CODIs. Now the reason I know it's a QI project is because, it says it right here. Sometimes that's not said very clearly. Again, with this abstract, you'll see there's a purpose there. It talks about how they implemented something, and then what their findings were. They go through the introduction again, which gives us a little bit, this tells us specifically of their problem, which was a cardiac ICU and a step-down unit within a hospital, and they had an increased rate of CODIs within a certain time period. So the purpose was stated over here, but right here again in this last paragraph of this introduction, it tells you more specifically what the project aims were. And this was to improve the patient outcomes, one, to reduce the CODI rates, but also to increase compliance with a nursing-driven catheter removal algorithm or protocol, which is the term I'm used to a little bit more. So it did have two specific aims. Now here it goes and talks about the project design and what they were doing, a pre-post kind of data collection and analyses. Then it talks about what model they used in the intervention, which was a CPDCA, which is a pretty well-known evidence-based practice model, and this model consists of 5 steps, and which was cool in the implementation process. They went through this, and with each 5 steps, they explained exactly what they were doing. And the nice thing is as they moved along, they communicated back. They gave feedback and they received feedback on each one of these steps from the stakeholders, and the stakeholders were, were the unit directors, the CNEs, and the nurses, and the clin nurse spec, and then of course the nursing staff. The people, the major stakeholder right here besides the patients, these are the people who had to implement this. So they went through and they explained sustainability. Remember, with the QI project, one of our things is we really want to sustain that change that is positive. This is their protocol. Now this is what was interesting, is that their second aim was to increase nurse adherence to the algorithm. The algorithm was introduced a year prior to this QI project. and people were not following it. So especially when it came to removal of the catheter, they didn't need a physician's order to remove a catheter if it met certain criteria, but nurses weren't doing that. They felt they needed to get that order. And so once they adhered to the protocol, it was found that and got those catheters out sooner, that CAUTI rate dropped. So let's go back right here. Okay, so the biggest thing here is, of course, your author, your year, and your title. The purpose of the problem. So I wrote the two aims. They wanted to implement the project to reduce CAUTIs, but they also wanted to increase adherence to the nurse-driven protocol. The review questions, if relevant, there really wasn't a specific question here, so I wrote none. Remember, this is your table, so fill it out so you can be able to pull information into that literature review. So even if a column you're not going to, it may not be applicable, I still sometimes put information in there. It's like, oh, okay, yeah, right, that's what that article said, and I can also go back to the article. Oftentimes I will put a link right here to get me to the article quick, although I will tell you I do save each article down in a folder. Okay, so review questions. There were none, but the author examined and discussed several QI projects that were conducted similar to this QI project. And I wrote C discussion. So that's not really a review question, but I just wanted to know how they compared the data. So was this a rigorous peer-reviewed process? Yes, and the reason I wrote that, it wasn't technically peer-reviewed. You will see that oftentimes in the CPGs and the expert consensus reports, but this was rigorously peer-reviewed because it did have they did go to the IRB. It was exempt, but they still went to the IRB, and they did not need IRB oversight. But the other thing is by utilizing this model, technically not peer-reviewed, but they went through this 5-way steps, and it occurred over 9 months, but they had consistent 2-way communication. So technically not peer-reviewed, but they did have 2-way communication. Okay, recommendations. Were the guidelines of the recommendations valid? These aren't guidelines per se. This again is a QI project, but and so oftentimes you can leave this blank as well, but I wouldn't, because you want some information here. And really in the end what their recommendation was, just for their notation, was that nurse-led interventions do influence patient care. It is a positive thing, but you have to have support from the top, meaning the leadership all the way down. And here I wrote the results that they had. They said fewer CAUTIs occurred. That was statistically significant. There was no change in the number of indwelling cath days, and then nurse compliance really increased by up to it did increase, but the compliance rate was 91%. So technically not a recommendation, like you will see in clinical practice guidelines or consensus experts guidelines, but I really wanted to get some information in there so it would tug my memory about this QI. So appraisal of worth. This is a good study the way it was done. The strength was they did talk about other QI projects, which I mentioned over here, and their results were very similar. So that's a strength. They used a great evidence-based practice model, and they had 2-way communication going all the way across. And this project lasted for 9 months, which really enhanced the sustainability of this change. And they knew what they needed to do to make sure in the future to make sure that nurses really followed this protocol as well. Limitation was a single site. That's just a given, but that's a limitation. The other thing is, and this goes back to positive, so I kind of bouncing around here, but they did have that meaningful communication all the way across. The strength was the algorithm didn't need to change, but it did change behavior, and that proved effective, which was great. And I love this because nurse-led interventions influence patient care, and that's very important. So those were the strengths of the QI article. And then this was just the one limitation. So the strength of evidence, going back to John Hopkins' table, when we talk about strength and quality of evidence, it's a 5 because it's a QI, and I gave it a B, just single site. If you go look at the criteria, you can see more of the details. So again, if you guys have any questions, make sure you ask. Thanks.